So today's discussion will be GI secretions, gastrointestinal secretion. So GI secretion, clear everybody? Clear everybody? Okay. GI secretion, সকালে খেয়ে ব্রেকফাস্ট করে কজন এসছে? ওরে বাবা, এত লোক ব্রেকফাস্ট করেছে। আর ব্রেকফাস্ট না করে কারা এসছে? ভেরি গুড, একজন দুজন তিনজন। তুমি ব্রেকফাস্ট করে না করে দুটোতেই তো হাত তুললে বোধহয়, না করে এসছো তাই তো? কেন প্রশ্নটা করছি? ব্রেকফাস্ট করে বা যখন আমরা ফেড স্টেটে আছি বা ফাস্টিং স্টেটে আছি, জিআই সিক্রিশনের কি কন্ডিশন হবে? আমরা যদি খাবার খাই তাহলে জিআই সিক্রিশন তার কি দাঁড়াচ্ছে, এন্ড ইফ উই আর ফাস্টিং তাহলে জিআই সিক্রিশন কি দাঁড়াচ্ছে? এখানে দুটো কনসেপ্ট থাকছে। ওয়ান ইজ basal output, the other is maximal output. Basal output, word gulo important. Basal output means even if you don't take any food, this amount of secretion will always be there in the GI system. Usually this amounts to 10% of the maximal possible output. যে কোনো secretion, be it saliva, যখন তুমি খাবার খাও না, suppose you are not eating anything for last 10 hours, saliva secretion you can understand, still saliva secretion happens, but the moment you take some food, saliva secretion increases. This gives us certain very important insight. First of all the GI secretion will be increased if there is some food or digestive product in that particular area, be it stomach, be it oral cavity, be it intestine, be it related to pancreas or bile. Everything we will cover today. Clear everybody? So this is basal output. এটাই যখন আমরা স্টমাকের ক্ষেত্রে আসছি, that is called দুখানা জিনিস আছে, BAO MAO, basal acid output, maximal acid output. বইগুলো খুললে যদি সময় পাও তাহলে দেখতে পাবে যে এর মধ্যে এই জিনিসগুলো প্রত্যেকটা লেখা রয়েছে। You need to reflect these things. তাহলে basal output এবং এই আমাদের ম্যাক্সিমাল আউটপুট। নেক্সট কামস টু একটা জায়গায়, পুজো আসছে, রাস্তা দিয়ে ঠাকুর দেখতে যাবে, বিভিন্ন খাবারের স্টলগুলো আছে, স্টলগুলো দেখা মাত্র দেখবে সিক্রিশন বেড়ে যাচ্ছে। কেন হয়? বহু দূরেই তো রয়েছে। একটা সংস্কৃতে একটা কথা আছে, ঘ্রাণেন অর্ধ ভোজনম, জাস্ট বাই স্মেল আমাদের অর্ধেক খাওয়া হয়ে যায়। তাহলে দুবার স্মেল নিলে আমাদের পুরো খাওয়া হয়ে যাবে। বাট এরকম হয় না অ্যাকচুয়ালি, হলে ভালো হতো, অনেকটা খরচ কমে যেত আর কি বেসিক্যালি। তোমরা হয়তো বলবে যে ক্যান্টিনে যা খাবার, বাবারে ওটা দুবার স্মেল নিলে হয়তো উই উইল গো মাচ হায়ার। এনিওয়ে, সো এইটা কেন হয়? দিস ইজ নোন অ্যাজ সেফালিক ফেজ। জাস্ট বাই স্মেল, সাইট, ইভেন থট অফ ফুড, তাতেও দেখা যাচ্ছে দেয়ার ইজ সাম সিক্রিশন, দ্যাট ইজ নোন অ্যাজ সেফালিক ফেজ। সেফালিক মানে কি? রিলেটেড টু ব্রেন। সো ফুডের যে কোনো স্পেশাল সেন্সে ফুডের যদি একটা ইম্পালস আসে তাহলেও আমাদের সিক্রিশন বেড়ে যাবে, সেফালিক ফেজ। দেন ডিপেন্ডিং অন দি পজিশন উই হ্যাভ গ্যাস্ট্রিক ফেজ, দেন ডিপেন্ডিং অন দি পজিশন উই হ্যাভ ইন্টেস্টিনাল ফেজ। মোর অর লেস যদি আমরা পুরো সিস্টেমটাকে দেখি, দেয়ার ইজ basal secretion, and it is in all types of secretion, saliva, HCl, intrinsic factor, intestinal juice, bile, pancreatic juice, everybody follows these basic things. And that's why the initial part of the class we have to be very well reversed through this particular area. Okay, basal output. The next one is maximal output, maximal secretion. And phases of secretion, যখনই একটা কেউ secretion সম্পর্কে লিখতে দেবে, the phases of secretion, the first one is cephalic phase, when just by mere thought of the food or sight of the food, your secretion, GI secretion will go up. After that, in case of esophagus, we have esophageal phase. Usually, in case of stomach, etc., we have gastric phase, and then we do have intestinal phase. এগুলো হচ্ছে more or less common for all types of secretion. And all these depends on cephalic, the way cephalic depends on sight, smell. Gastric phase depends on presence of food in the stomach. Intestinal phase depends on presence of food in the intestine, food or digestive product, kind of that. So that way the whole things continue. Now coming to the control of such secretion. আমি একটা খাবারের স্মেল পাচ্ছি, তাতে কি করে হচ্ছে? হোয়াট ডু ইউ থিঙ্ক? সিক্রিশন বাড়ছে কেন? জাস্ট বাই থিঙ্কিং অফ সামথিং। So secretion depends on few things. Nerve impulse, and this nerve impulse may be central nerve impulse, not CNS, ANS, autonomic nerve impulse. That means parasympathetic and sympathetic. And this nerve impulse may be local nerve impulse, ENS. That means Orbeck plexus, Meissner plexus. Connect with the, every class will just be transformed into the next class. So the last one should be transformed, and you should reflect and refer to the previously learned things. কারণ এরপর তো বই খোলা সময় পাবে না, এত ব্যস্ত প্রত্যেকে কেউ বই খুলে না। বইয়ের আমরা অনেক সময় পরীক্ষাতে জিজ্ঞেস করি বইয়ের প্রচ্ছদ যেটা, দ্য ফার্স্ট কভার পেজের কালারটা কি পরীক্ষাতে, এরকম কন্ডিশন আসে আর কি। বইটাই দেখেনি বেসিক্যালি, সেটা বলতে পারলেও 10-এ 2 দিই আমি। রিক্সা ভাড়ার জন্য 1, হলে এসছো, আর বইয়ের তাহলে 10-এ 3 সিকিউর। রিক্সা ভাড়া বা টোটো ভাড়াতে হলে আসতে হয়, তো এই দুটো। এরপরেরটা হচ্ছে পড়ে করতে হবে, বাকিটা পড়াশোনা করে আনতে হবে আর কি বেসিক্যালি। ক্লিয়ার? সো বেসিক্যালি তাহলে আমাদের ফার্স্ট ইজ ANS, the second is ENS. ENS মানে Meissner plexus, Orbeck plexus. If you remember, longitudinal muscle chilo, circular muscle chilo. And in the submucous level, there were multiple glands, nerve fibers, blood vessel, if you remember, from the cross section. You can also refer back to the previous class diagram. Clear? Erpore jeta asche, the third one is the chemical. By chemical, it is the food itself as a chemical reactor. The digestive juice from the previous portion, যখন intestine যাচ্ছে, stomach acid becomes one factor. Clear? Not only that, neurochemical, that means all the neurotransmitter. Last class I have mentioned, what are the neurotransmitter? Acetylcholine, adrenaline, noradrenaline, histamine. Clear? Then VIP, NO, all those were written. So these neurotransmitter, substance P, if you remember. So all these neurotransmitter helps in increasing the secretion. Clear everybody? So far, তাহলে খুব কুইক যদি করি, food, presence of food, thought of food, sight of food, or actual presence of food, all can increase the GI secretion throughout the GI system. And there are multiple phases of GI thing: cephalic, gastric, intestinal, esophageal, kind of that. Even if we don't take any food, still there will be some basal secretion. It will never be dry. There will always be some basal secretion, and whenever adequate environmental support is there, that means digested product is there or some other hormones are working, immediately you will see increase in GI secretion. এইবারে একটা ছোট্ট কনসেপ্টে আসি। All the GI secretion that so far we were discussing were enzymes. Are there any GI hormones? GI এ কোনো হরমোন আছে? জোরে বলো, একজন বলো। গ্যাস্ট্রিন, সিসিকে, কোলেসিস্টোকাইনিন, প্যানক্রিয়াজাইমিন, সিক্রেটিন, মোটিলিন, গ্রেলিন, অনেক আছে হরমোনস, মানে অনেকগুলো হরমোন রয়েছে, এগুলো শর্ট নোট আসে, এটাও পরে পড়ানো হবে সেপারেটলি। বাট রিমেম্বার, এই হরমোনগুলো, these hormones are also extremely important because some of them increases the secretion, some of them reduces the secretion. Clear everybody? They are hormones but they have a capacity to increase the secretion of enzymes. Clear? হয়ে গেল? Now we are coming to saliva. So ছোট ছোট করে you can start taking notes. So saliva is the first secretion. বইগুলো খুললে অনেক কিছু পাবে, অ্যান্ড এভরিবডি, বিকজ আমাকে একটা ক্লাসে এতটা শেষ করতে হবে, সেই জন্য প্রত্যেকটা টেবিলে আমি যাচ্ছি না। দ্য সিম্পল থিং, ওগুলো বইতে খুললেই পেয়ে যাবে। যে কোনো সিক্রিশন, ইফ দে আস্ক অ্যাবাউট দি কম্পোনেন্টস, বাইলটা একটু বলে দেবো তাও, যে কোনো সিক্রিশন ইফ দে আস্ক অ্যাবাউট দি কম্পোনেন্ট, ডিভাইডেড ইন্টু ওয়াটার অ্যান্ড সলিডস, ডিভাইড দ্য সলিডস ইন organic and inorganic, divide the inorganic into cations and anions, and you all know cations and anions better than me, write those. And under the organic, think organ specific thing. Jodi stomach hoy, there will be pepsin. Jodi saliva hoy, there will be alpha amylase, lingual lipase. Jodi stomach hoy, gastric lipase. If it is pancreas, there will be proteolytic enzyme, lipolytic enzymes. And think of some proteolytic enzyme like that can be trypsin, that can be chymotrypsin, carboxypeptidase, etc. Also mucin to some extent, you can write over there. Intestinal secretion, mucin will be there. Kind of this, okay? Bile er khetre we will have a chart, but more important things are there which I need to cover today. So we will start from saliva. So saliva, the overall whole day in a normal person, total output of saliva is 1.5 liter per day. First of all, 1.5 liter per day. And normally, remember one thing, saliva is usually isotonic to plasma. Isotonic to plasma. And why it is isotonic to plasma? Because initially when it is secreted, sodium level in saliva is high. But saliva passes through multiple salivary glands. And what are the salivary glands? Parotid, submaxillary, submandibular. All these glands do have canaliculi. And all these canaliculi do have epithelial cells. So whenever saliva passes through that, water will be absorbed, sodium will be absorbed. So the more it passes, sodium absorption happens, and actually in saliva, what happens? After multiple pass, water level reduces, potassium level goes up, and bicarbonate level goes up. So in normal condition, saliva is a potassium-rich fluid. And since water goes away that way, that tonicity changes. Understood? So normal condition, saliva is a potassium-rich fluid because sodium is absorbed after multiple pass. But when salivary secretion frequency increases, ধরো তোমার একটা হঠাৎ করে একটা লঙ্কা মুখের মধ্যে পড়ে গেছে, স্পাইসি, সাথে সাথে saliva secretion gets increased. At that time, what will happen? More and more saliva secretion, but saliva won't get time to pass through canaliculi. So if we take that saliva, you will see sodium level is high. That saliva won't have potassium level high. Clear everybody? And salivary secretion follows the same thing. প্রত্যেকটাতে এক জিনিস লিখবে, cephalic phase আছে. Just by thinking of a particular food, saliva secretion increases. Pavlov's experiment. If you remember Pavlov's experiment, the bell was rung and the food was given. Bell was rung, food was given, saliva secretion increases. This continues for few days, then bell was rung, food was not given, saliva secretion still increases. The way election happens. You give something, 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 you take everything. Kind of that. So similar, this is a reflex. So this is a reflex. That way, in dog that happens, in human that happens. So simple thing. And this is a usually it's a conditioned reflex. Condition means we give certain condition and some other sensory modality being conditioned to that. বেলে কি হচ্ছিল? শুনছে, saliva শোনার সাথে ফুড কে ফার্স্টে রিলেট করছে। সো দ্যাট ইজ দি কন্ডিশনিং। সো আ টাইম কামস যখন ফুড না থাকলেও শোনার সাথে স্যালাইভাটা কানেক্টেড হয়ে যাচ্ছে। শোনা, ফুড, হিয়ারিং, ফুড, saliva. Hearing, food, saliva. That's the conditioning. And a time comes when conditioning loop is organized, hearing, saliva. Food is not needed. Clear? This is conditioned reflex, and this is a part of cephalic phase. And cephalic phase depends on which nerve? Vagus nerve. Last day I have also told you a story. Parasympathetic increases the GI secretion. Which one is parasympathetic nerve here? Vagus nerve. And what is the which one is the parasympathetic neurotransmitter? Acetylcholine. Clear everybody? That's it. Okay. Saliva contains two particular enzyme. One is alpha amylase, which is important for carbohydrate, and that is only active inside the oral cavity, mouth cavity. The moment it goes to gastric area, low pH inactivates this. So its action is not there. And the second one is lingual lipase. And it is just the opposite. It means something related to tongue. So lingual lipase, and as the name suggests, lipase, it means it is breaking down lipids. ASE means it is breaking down whatever is there in the prefix. Clear? Lingual lipase doesn't act here. It requires stomach pH to be activated, just the opposite, inverse relation to that. Clear everybody? Huh? Okay. So that was all about saliva mostly. There are certain clinical application. There are certain diseases in which salivary secretion dries up. There are certain diseases. Artificial saliva is also there. It is used as a treatment. যদি saliva dry up হয়ে যায়, there are certain medication, অনেক বয়স্ক লোক কিছু medication নেন যাতে salivary secretion dries up. Occasionally, in certain condition of neurological issue or particular medication, salivary secretion may increase. Facial nerve palsy হয়ে গেছে, একটা সাইড থেকে saliva continuously dribbling হচ্ছে. So all these are related pathology to saliva. You just have to have an overview that these are the conditions and there are certain treatment approach. That's it. Just back in the mind, keep it. When you are, satisfying the examiner by answering other previous questions, only then this kind of questions will be asked. Clear, everybody? Next one is stomach, and that's the major area where multiple questions will be asked, both in viva, practical, and theory. So you all know about the stomach basically. So this looks like this, and there are certain parts of stomach. The top part of the stomach is the esophagus. Then we have the fundus this side, the body this side, and lower part pyloric antrum. Clear? We are talking about the secretion. So there are multiple cells in stomachs which will secrete certain things. Parietal cell, oxyntic cell. What is the secretion from there? HCl. What is the secretion of peptic cell? Pepsinogen. From where intrinsic factor is secreted? Oxyntic cell. Can you tell me one question? Suppose which part of stomach is most important for life? If I cut stomach, আমি বাদ দিয়ে দিলাম একটা experimental animal থেকে, if I just dissect the stomach out, if I connect the esophagus to the duodenum and jejunum, there is no stomach in between. Can that animal survive? No. Why? খেতে পাবে না বলে? You can give him liquid. You can give him partially digested food. You can give him already acid pepton from outside. জোরে বলো. What in stomach crushes the food? I will give him crushed food. I will give him crushed food. Intrinsic factor is necessary for life, survival. Stomach action is not ultimately necessary for survival. Clear? If you cut stomach, the patient or the animal will not die due to hunger if you keep on giving things. Intrinsic factor is the life-saving thing here. Because intrinsic factor is important for vitamin B12 absorption. And if vitamin B12 absorption is not happening, what will happen? The neurodegeneration. Myelin sheath তৈরি হচ্ছে না, neurodegeneration হচ্ছে. Clear, everybody? And neurodegeneration will definitely lead to, it will hinder the survival. যদি একদম neurodegeneration পুরোপুরি হয়ে যায়, কোনো নতুন নার্ভ ফাংশনই করছে না, definitely the animal can't survive. Food you can give, even semi-solid food, keep on giving. Already partially digested food, keep on giving. Other parts will do. There are operations, there are surgeries where stomach is taken away, still the patient survives, because in such cases we have to continuously give them vitamin B12 from other route. Food route নয়, injection through দিয়ে তাদেরকে দিয়ে যেতে হবে. Then lifelong they will take that and they will survive. Clear? অনেক অপারেশনে স্টমাকে ধরো there is a cancer, stomach বাদ গেছে, patient can survive, no problem. Only thing you have to take care of the vitamin B12 level in the body. Because IF is not there, intrinsic factor is not there, so I have to give vitamin B12 injectable, intramuscular injection দেওয়া হয়. Clear, everybody? Can understand? Vitamin আমরা খেয়েও vitamin, oral vitamin B12 medicine আছে, there is oral formulation, but for that you need an intact stomach. If you don't have an intact stomach, or অনেকের ক্ষেত্রে দেখা যায় যে stomach is there but intrinsic factor level is low, maybe there is some issue, that's why that is not working out. Maybe some antibody, antiparietal cell antibody is there, and that's why, or anti-intrinsic factor antibody is there, and that's why those are not being formed. Vitamin B12 deficiency is happening. So in these patients, oral vitamin B12 will not work. You have to give parenteral vitamin B12. Parenteral means apart from oral. So either you have to give IM somewhere, maybe in the buttocks, maybe in the deltoid. Usually we give in the hip area. So vitamin B12 injection we need to give to this kind of patients. Clear, everybody? Now coming to parietal cell and how HCl is being formed. That's very important. How HCl is being formed. And this is a question for your examination. So I will draw and this drawing is necessary because this is a theory question for 5 marks basically. Suppose this is the cell. So which cell secretes HCl? Oxyntic? Parietal? Which cell secretes HCl? Okay, okay. So this is the lumen side, gastric lumen side, and this is the blood side. And this is the HCl secreting cell. Clear? Now what is happening inside? Inside there are few reactions which are happening. Certain transporter or certain molecules which transports molecule or exchange molecule, those are important. Certain ATPs are important. I am coming to that one after another. So inside this cell, H2O converts or H2O reacts with CO2 and they form H2CO3, that is the bicarbonic acid. And from there it is divided into H plus HCO3 minus. This equation or reaction is a bidirectional reaction, okay, but rightward or downward speed increases in presence of carbonic anhydrase. So if there is carbonic anhydrase, H2 and CO2 speed will be increased. So rightward or downward reaction speed of 5,000 times it might increase if carbonic anhydrase is present. If carbonic anhydrase is not present, backward reaction can also happen. That means intermediaries where theke jabe. Carbonic anhydrase thakle we will get more supply of H plus and HCO3 minus, and that is present. Carbonic anhydrase is present there. Now this HCO3 minus, what it does, this HCO3 minus goes back to the blood. HCO3 minus goes back to the blood, and since HCO3 minus is an anion or cation? Anion. So one anion goes out, and is it a monovalent or divalent? Monovalent anion. So I need another monovalent anion to compensate for the electroneutrality. So it will be exchanged against chloride. It will be exchanged. CO3 goes out, one chloride comes in. So basically chloride comes from blood into this cell. There is one exchanger, and this exchanger is known as anionic exchanger. The other name is chloride bicarbonate exchanger. Okay, chloride bicarbonate exchanger, that is working on that side. This chloride comes up here, and this chloride passes through the lumen via chloride channel. So there is chloride channel, and this chloride channel releases this into the lumen. Okay. Now in gastric lumen, can you tell me what is the pH? 1.5 to 2 or 1.5 to 2.5. And what is the pH? Negative logarithm of concentration of H plus. So low pH means H plus is in millions. Remember? So, and what is the pH in this cell? Physiological pH, 7.4. So that is also negative logarithm of H plus ion. Will be low or high inside the cell? Low, because pH is high. pH is high inside the cell. It is somewhere around 7.38. So definitely H plus level will be very low. So whatever H plus is being formed here, the concentration of this H plus is much lower than the concentration of already present H plus in the lumen. Clear for everyone? Clear everyone? Now for HCl secretion, what we need? New H plus to enter the lumen continuously. আগে যা ছিল তা তো আছেই, সেটা তো already HCl করেইছে. But day long if I have to secrete HCl, what do I need? New H plus from the cell itself. Okay? So new H plus কি করে এখানে আসবে? The concentration gradient is heavily against the H plus transport. So we need certain thing which will electrically and chemically benefit this reaction. So anybody having any idea about active transport, where ATP is needed and ATP's energy is utilized? Primary active transport means this one molecule is exchanged against another molecule and ATP completely utilized for that, while the movement is happening against the concentration gradient. Clear, everybody? So here what happens? Here we have, again, you need to remember, one H plus going out means one monovalent cation cell is losing. So to maintain the electron neutrality, again, I do need some monovalent cation to go in. So there's an exchange pathway is happening, and this is one H plus goes out, one potassium goes in, and the whole thing, the director of this whole movie is ATP, and this is a pump, and this pump is known as H plus K plus ATPase pump. The other name of this pump is proton pump. This is also known as proton pump. You may ask me why proton? H plus is a proton plus neutron. Nobody cares about them because they are neutral. Nobody cares about neutral persons in this world. Everybody is cute. So here also proton pump means H plus. So H plus, K plus, put ATPase pump or proton pump. This is the thing. So what happens when these proton pumps are working? H plus is being secreted into the lumen, and now in the lumen we have sufficient amount of H plus and sufficient amount of new chloride, new H plus and new chloride, and they are converted into HCl. So that is the way HCl is formed in the GI tract. Clear, everybody? Clear, everyone? Okay, good. Any other observation that you have from this picture? H plus coming out, Cl is working, H plus HCl is formed in the lumen. In the blood side, any other picture that is happening? Does blood get anything new? Bicarbonate, very good. Bicarbonate, that means what? The more HCl is produced, the more bicarbonate will be in the blood. This picture says that. Clear na? It's a continuous process. The more HCl produced, the more bicarbonate is in blood. Now, the more bicarbonate in blood, ultimately that blood will be filtered in the glomeruli in the kidney. Clear? If that blood is filtered in the glomeruli in the kidney, what will happen? This extra bicarbonate will come into what? Urine. So more HCl is formed when we have actually food. So after taking food, HCl secretion goes up. Clear? So after taking food, HCl secretion goes up. Simultaneously, blood bicarbonate also goes up, and simultaneously urine bicarbonate also goes up. And this is known as postprandial alkaline tide. Short note for you: postprandial alkaline tide. This is the short note. Postprandial alkaline tide means after you take food, blood bicarbonate goes up and urinary alkalinization happens, because that blood will altogether going to be, alkalinized, or excreted via the urine. Simple thing. So this is a short note: postprandial alkaline tide. ছবিটা আঁকো পুরোটা। সব জায়গায় অসুবিধা, কারো না কারো অসুবিধা হবেই। ছবিটাকে কমপ্লিট করো। উইল অলসো হ্যাভ টু অ্যাড আ ফিউ থিংস। অসুবিধা হলে আমি বলে দিচ্ছি কয়েকটা জিনিস। দিস ইজ H2 রিসেপ্টর, দিস ইজ somatostatin রিসেপ্টর, দিস ইজ prostaglandin receptors, এখানে এটা হচ্ছে CCK রিসেপ্টর, and that is M3 receptor. This is CAMP, cyclic AMP, which comes from the ATP breakdown away, and the enzyme which is required for that is adenylyl cyclase. If you remember, ATP is broken down into ADP, ADP is broken down into AMP, AMP further via adenylyl cyclase undergoes transformation and it becomes cyclic AMP. Now on H2 receptor, and histamine is secreted like cells, ECL. Histamine is secreted from enterochromaffin like cells. M3 receptor on which ACH works. So ACH acts on M3, that leads to parasympathetic secretion or vagus. This is H plus A plus KTPase here, sorry, H plus K plus ATPase here, and this is HCl which is secreted from H plus K plus ATPase. Just now we have discussed, and those are the proton pump. H plus A plus ATPase is proton pump. There are certain medication which may inhibit this one. Those are known as proton pump inhibitors. There are certain medication which inhibits H2 receptor, and those are known as H2 blocker. And I am writing the name of H2 blocker on this side. Many medication like cimetidine nowadays not used anymore, ranitidine, etc. And these are important for your examination in explain why questions. Famotidine, ranitidine, you know, these are medications are used much for acidity, and these are proton pump inhibitors. These medications names also important for examination: omeprazole, pantoprazole, lansoprazole, many such. So prazole is basically PPI, proton pump inhibitors, which helps in stopping the work of the proton pump, and stopping the work of proton pump means HCl will be less. So complete this. This one will be more complex. We will be putting more things into it. I'm giving you 1 minute to complete whatever we have written over there. Similarly, you can, if you look closely to the picture, and if somebody has issues to look at it properly, you can also take a snapshot and magnify, and from there you can study. That is one option. People who prefer the backside, for them that's the option. Okay, so this H2 receptor, once histamine acts on the H2 receptor under normal condition, not when H2 blocker is working, under normal condition, when histamine acts on the H2 receptor, that actually initiates the CAMP reaction, ATP, ADP, AMP, CAMP, this reaction under the function of the, there is also something called PKA, protein kinase. So these reactions do happen. You don't have to make it that complicated. Anyway, the CAMP will act as a stimulant to more and more H plus K plus ATPase action. So if we can stop the CAMP action again, H plus K plus ATPase action will be low. So you can see that somatostatin, when it acts on SR, that is somatostatin receptor, or prostaglandin, when they act over there, what they do? They reduce the CAMP. You can see now they are inhibiting. Somatostatin and prostaglandin, they are inhibiting to the CAMP. If CAMP is inhibited, what will happen? CAMP stimulates this, then stimulated this, then stimulated this. But if I inhibit CAMP, this is not happening. This is not happening means this is not functioning. This is not functioning means this is low. Clear, everybody? So, somatostatin reduces the secretion, that is the pathway. Prostaglandin reduces the secretion, that is the pathway. And that's why prostaglandin is very important to maintain the stability of stomach. Because beshi jodi acid hoy, the stomach will be auto-digested. There are mainly 2-3 factors which are important in prevention of auto-digestion of stomach. Stomach e to eto acid ache, stomach to digested hoye jacche na. What's the reason? Because of the presence of tight junction. যেটা হচ্ছে acid that cannot pass through, lumbering থাকবে, that cannot infiltrate back into the cell. If that cell is exposed to stomach acid, cell will die simply. Second is there is a layer of mucin. There is a layer of mucin, and that's why the most corrosive part of the HCl never comes in contact with the actual cell. That is the second thing. Third, the presence of prostaglandin that down regulates the H plus K plus ATPase level and reduces the overall HCl level. So this way, stomach is not auto-digested. 3 factors: tight junctions in the epithelial barrier, presence of mucin as a protector, and factors which reduces the H plus K plus ATPase function, most important of them being the prostaglandin. So these 3, likle 5-5. With this picture, একটা লিখলে সেরকম marks, all depends. So this is also another explain why question for you. Next, coming to here, ACH, what it does. So vagus nerve secretes neurotransmitter acetylcholine. Neurotransmitter acetylcholine acts on M3 receptor. মাথায় রাখবে, parasympathetic 2 types of receptors are there. One is muscarinic receptor, it is just for your general knowledge. The other is nicotinic receptor, এটা হচ্ছে parasympathetic receptor we are talking about. So ACH, acetylcholine, acts through these 2 receptors all over the body. Why receptors are important? Without receptor nothing will happen. If you have a plug but no socket, it is useless. Similarly, if you have neuromodulators, you have hormones, but no receptor is present, or no receptor is functional, it becomes useless. So all of them needs a vehicle to work upon, and that M3 is the vehicle for them, M3 receptor. What is M3? Muscarinic receptor subtype 3. That is M3. Clear? Kichu nicotinic receptor আছে, out of the context in today's class. But M3 is muscarinic receptor subtype 3. Okay? সেখানে কাজ কে করছে? ACH, acetylcholine, and how it works? এটা IP3 DAG ক্যালসিয়াম পাথওয়ে দিয়ে কাজ করে, ইনোসিটল থ্রাইফসফেট ডাইএসাইল গ্লিসারল calcium pathway. You don't have to remember, these are the second messenger in examination, second messenger biochemistry te ashbe, and you need to connect this IP3 DAG pathway দিয়ে they are working, and they actually increases the expression of H plus K plus ATPase. একদম simply বললে ACH ভেগাস থেকে বের হয়ে M3 এর উপর কাজ করে, that increases the expression, increases the function of H plus K plus ATPase. So if I can get something which blocks this acetylcholine function, definitely acid secretion will come down. Clear? So who can block the acetylcholine function? Atropine. Acetylcholine function উপরে ব্লক হলে একদম ডাউন দি লেভেল এটা কমে যাবে। ক্লিয়ার এভরিবডি? উপরে ব্লক হলে ডাউন দি লেভেল ওইটা একেবারেই কমে যাচ্ছে। নেক্সট ওয়ান, জি, সেখান থেকে গ্যাস্ট্রিন, and gastrin acts on CCK-PZ. That is the pathway. So gastrin acts on CCK. This is a receptor, cholecystokinin B type receptor, CCK-B receptor. This one. Gastrin comes from the G cell, and we all know, na, gastrin increases the secretion. Clear? So gastrin acts there, acts on the CCK receptor. and that acts through the IP3-DAG pathway, the second messenger pathway. That activates the H plus K plus ATPase. So therefore, HCl is blocked. Clear everybody? তাহলে এইগুলো হচ্ছে pathway, the chemical pathway and neuronal pathway. Neuronal pathway is this, vagus, neuronal pathway. So control of HCl secretion, this is the control of HCl secretion. And the medicines, মেডিসিনের নামগুলো আসবে, যে কটা লিখিয়েছি সে কটাই আসবে। মেডিসিনের এর বেশি জানতে হবে না, কিন্তু তোমাকে বুঝতে হবে, ইউ নিড টু আইডেন্টিফাই প্রেজল যদি নামের শেষে থাকে, দ্যাট ইজ আ প্রোটন পাম্প ইনহিবিটর। টিডিন যদি নামের শেষে থাকে, অ্যাটলিস্ট হিয়ার, পরে আরো আসবে, র্যানিটিডিন, সিমেটিডিন, এইটুকু, অ্যান্ড ফ্যামোটিডিন, এই নামটা মাথায় রাখতে হবে। অকেশনালি ইউ মাইট এক্সপেক্ট আ কোশ্চেন যেখানে H2 ব্লকার না বলে র্যানিটিডিন দিয়ে কোশ্চেন আসতে পারে, ইন দিস ইয়ার অনলি। সো ইউ নিড টু রিমেম্বার দিস, ওকে? অ্যান্ড দে মাইট, এগুলো সব এক্সপ্লেন ওয়াই। This is a full 8 marks question if they ask you the control of HCl. But the partially, এই যেগুলো এর মাঝখানে থাকলো, একটা পিকচার থেকে multiple explain why question comes. They will ask proton pump inhibitors are used in peptic ulcer disease. Explain why. That's the reason. Peptic ulcer means what? Ulcers means what? Ulcers means there is a breach in mucosa. Breach in mucosa. If breach means ধরো এখানে কিছুটা জায়গা থেকে রংটা উঠে গেছে, so that is a breach. Breach in continuity of the mucosa. তা যদি হয়, if there is a breach in mucosa, what will happen? The acid which were actually away from the actual cell surface, now that will come and hit the mucosal surface. It will corrode the mucosal surface. If the level is high, if the ulcer is deep, it will corrode the submucosal area. And you remember, submucosal area do contain the blood vessel. So if it is corroded, blood will come out. So bleeding gastric ulcer will only happen when at least submucosa is breached. Remember? So that means the severity is increasing, because that acid will definitely corrode. 1.52 means that is the HCl is very highly corrosive toxic substance. So if the protective layer is breached, definitely we will see something like that. Again in ulcer disease treatment, we occasionally use certain substances which increases this level of this. There are certain medication with which, but সেগুলো তোমরা next year in pharmacology you will learn about those medication. So medication that improves the PGE2, prostaglandin E2 expression, that actually কি করবে? Negative to camp, that means downward everything negative. তাহলে PGE2 যদি আমি বাড়িয়ে দিই, H plus K plus ATPase কমে যাবে, HCl function will go down. So that is also an ulcer protective way. So prostaglandin plays an important role in prevention of ulcer. That's the answer. Clear? এইটা পাতে, এই একটা থেকে you will get multiple questions where you can answer simply. একটা ডায়াগ্রাম, এটা বইতে অনেক পাতা ধরে লেখা আছে, you just read through, go through this, and then in proper English complete this in the examination. That's it. এতেই প্রচুর, out of 5 you will get 4, এইটুকু পড়ে গেলেই। Clear? So this is all about that. So peptic ulcer disease জিনিসটা কি? It is the breach in mucosa. So peptic ulcer, there are multiple factors which can cause this. Maybe যাদের irregular lifestyle থাকে, irregular lifestyle থাকলে কি হচ্ছে? Proper food is not there, acid secretion হচ্ছে to some extent. So there is higher chance of injury. Okay. Similarly, smoking, certain substance abuse, alcohol, all can increase the chance of injury. Spicy food, very hot food can increase the chance of injury. There is some bacteria called H. pylori that can increase the chance of injury. Okay, H. pylori সেটাও কিন্তু ulcer disease এর সঙ্গে connected. Clear? হ্যাঁ, ওটা ইনফেক্টিভ কারণে হচ্ছে। There might be some corrosive material they have ingested that might lead to injury. অনেকে suicidal ideation এ কিছু corrosive substance খেয়ে নিয়েছে, there will be major injury over there, and also we need to give something. There is one medication called sucralfate, এক্ষুনি জানার দরকার নেই, মানে মনে রাখার দরকার নেই, দ্যাট অ্যাক্টস অ্যাজ আ প্রোটেক্টিভ লেয়ার ইটসেলফ। ওই জন্য গ্যাস্ট্রিক অ্যাসিডিটিতে অনেক সময় আমরা সুক্রাল ও সিরাপটা দেওয়া হয়, ওটা কিছু না একটা প্রোটেক্টিভ লেয়ার করে দেবে, মিউসিনের একটা লেয়ার, জাস্ট এ ফিজিক্যাল ব্যারিয়ার। সো আলসারটা, দি আলসার অর দিস কাইন্ড অফ ডিজিজেস ক্যান হ্যাপেন ডিউ টু ফিজিক্যাল রিজন, ব্যারিয়ার চলে যাচ্ছে, ক্যান হ্যাপেন ডিউ টু কেমিক্যাল রিজন। ফিজিক্যাল রিজনের মধ্যে হাই স্পাইসি, হাই টেম্পারেচার ফুড ক্যান লিড টু দিস। ক্লিয়ার? কেমিক্যাল রিজন, বায়োলজিক্যাল রিজন, H. pylori. Clear everybody? Next we come to pancreas. Next we come to, and this also follows the cephalic, gastric, intestine phase. Cephalic phase, when you see some food, HCl secretion goes up. When we take some food in oral cavity, HCl secretion goes up. When actually food is present in stomach, 70% of HCl secretion happens then. And when partially digested protein goes into the intestine, HCl secretion still goes up a little bit. So that is the intestinal phase. আমাদের স্টমাকে কি হচ্ছে? অ্যাসিড পেপটোনে কনভার্ট হচ্ছে। বেসিক্যালি স্টমাকে পেপসিনোজেন and HCl, these are breaking down the protein. HCl is breaking down the stuff bond in the protein, converting in acid peptone, and further it will help in formation of the acidic chyme, which will ultimately be digested in further distal part of the GI tract. Pepsin, which comes from the pepsinogen, that is also important to break down the collagen bonds in the food. এগুলো ছোট ছোট MCQ কিন্তু যা বলে যাচ্ছে এখান থেকে MCQs or OSPতে কোশ্চেন আসবে. So pepsin helps in breaking down the collagen bond. Collagen bond is very tough. Without particular molecule, you can break it. না হলে একটা, and collagen is everywhere in the cartilage. So আমি চিকেন খাচ্ছি, chicken has a lot of collagen. কে break down করবে? This fellow will break it down. This fellow will help in digestion. Clear everybody? Now we are going to pancreas. Pancreas এর ক্ষেত্রে you must know that pancreas is the organ in human body which produces maximum protein per gram tissue. Pancreas produces maximum protein per gram tissue. It's the only organ in human, or it's the chief organ in human body যে এটা করছে maximum protein synthetic output comes from pancreas. Pancreas again, it's wonderful, it's a mixed gland. It has exocrine, it has endocrine part. Exocrine part has enzymes. So all the enzymes that is the topic of this class or this subsequent classes. Endocrine part, that is the islets of Langerhans, and that has number of dedicated cells for hormones. Alpha cell, glucagon, beta cell, sulin, gamma cell, F cell, D cell. তোমাদের এটা হোম টাস্ক কি কি হচ্ছে, হ্যাঁ, প্যানক্রিয়াটিক পলিপেপটাইড বলে কিছু আছে কিনা, all these things you need to go through. Okay, can gastrin be secreted from pancreas? That is also a question. হ্যাঁ, এই কোশ্চেন গুলো বাড়িতে গিয়ে সার্চ করবে। ক্লিয়ার? Now coming to the fact that pancreas থেকে the first proteolytic thing or whatever proteolytic things or enzymes are secreted from pancreas, they are secreted, synthesized and secreted as inactive form. That's why pancreas is not auto-digested. Again an MCQ, again an explain why question. Why pancreas is not auto-digested? Because pancreatic enzymes, they are formed and secreted from pancreas in an inactive form, and the most primitive inactive form is trypsinogen. That is the first one. Trypsinogen, that is the first inactive form of substance that comes out of pancreas, and they are released in, what is the next step? Duodenum. Intestine এসে trypsinogen release হলো. In intestine we have one enzyme, and this enzyme known as, and this enterokinase is a fantastic switch. It will switch on trypsinogen, it will form trypsin. বাকি সব নাম তোমরা জেনে এসছো, chymotrypsinogen to chymotrypsin, inactive carboxy or pro-carboxypeptidase to carboxypeptidase, pro-elastase to elastase. সবগুলো ফর্মুলা runs through enterokinase. Enterokinase, the moment trypsinogen to trypsin, cascade reaction, bloodের যেমন clotting a cascade reaction আছে, similar cascade reaction. Now this trypsin, it will inactive chymotrypsin to active chymotrypsin, that will inactive pro-carboxylase to carboxypeptidase, that will pro-elastase to elastase. That's a cascade reaction. So all these enzymes will be important, and these all are proteolytic enzyme. Elastase মানে কি, elastin breakdown করছে. These are tough protein, and we need very specific specialist who will break it down, and these are the things. Clear everybody? So it is all about the pancreas. Now can pancreas be auto-digested? Usually not, but in pancreatitis it happens. In pancreatitis means inflammation of pancreas. So there will be severe damage to this pancreas in this condition. Clear, everybody? So remember, pancreas also do have similar gastric phase, similar intestinal phase, to some extent very limited, cephalic phase very limited, and two major hormones, GI hormones, that works with pancreas in this phases. One is CCK, the other is secretin. So CCK and secretin, these two hormones, CCK and secretin, these two hormones are modulator of pancreatic function. So just 2 minutes I will take, and then I need to stop this class today. Whatever is left we will continue after the vacation. So the next thing is bile. Next is bile, and bile contains a number of things. There will be water, there will be cholesterol, there will be bile pigment, there will be bile, bilirubin, etc. There bile acid, taurocholic acid, glycocholic acid. There will be ions, a lot of things in bile, and bile secreted from hepatic duct, bile secreted from hepatocyte, bile secreted from the canaliculi in the liver, and bile is stored in gallbladder. So there will be a fundamental difference between the texture of liver bile and gallbladder bile, and that's why that is asked multiple times in the examination. One note just today, the last line, which will help you to connect and reflect, and then from here we will start in the next class, that gallbladder helps in acidification, dehydration, and concentration of liver bile. So gallbladder, what it does, actually in gallbladder liver bile is stored, and when it is stored there, the pH of bile falls down, there is acidification. Then the water in bile is absorbed, so concentration and dehydration. So pH comes down, solids goes up, water comes down, and that's why it's very evident that liver bile contains 98% of water and gallbladder bile contains 89% of water. Now you open your book, you go through it, and we will start from here in the next class. Whatever is left in 4.2, and then as subsequent things which will be given, 4.3, 4.4 onwards after puja. Happy puja to all of you. Thank you.
So we talked about this particular chromosomes and the karyotyping method procedure beforehand, and classification method as well in the previous session. We continue to talk about the genetics. As I mentioned, it is very small content of the genetics is given on the gross anatomy or in anatomy. We are not going to large a great deal of human genetics. We are only focusing on the genetics which is replicable, doable on a clinical setting, and rest of the genetics will be covered in the biochemistry or biochem sessions. Now for the part we have covered till this karyotyping and identifications of the chromosome, that process and procedure sometimes is important to understand how these particular chromosomes can be visualized, because it is an intracellular, internuclear placed chromatin fibers are there. We need to see them, and we have to get some techniques to just like bring them out and see it, stain it, and identify it. And that particular identification as well as placing it in a proper way of plating it, we call them as karyotype and ideogram. That helps us to understand whether we are going to have any disease or not, or we can understand this process of these genetic evolutions, how it is going on. So that's those things related to the karyotyping, the clinical aspects, we are coming into it slowly. So today we are going to talk about this phenomenon, we call them as Lyon hypothesis and the Barr body, which is maybe familiar with you or may not be familiar, but I am just going to discuss about it. And next we will be going to the next phase of the chromosomes or genetics part. We call them as chromosomal error or known as chromosomal aberration. That's part we will be introducing. And we will be taking this like half an hour to 40 minutes class to discuss about it. So we have talked so far about this particular phenomenon, what is chromosomes, and how to identify the chromosomes and how to classify it. And based on this particular advanced classification, we understand this particular chromosomes is nomenclature. And to identify this kind of pictures, we have to go for a series of the procedures. That's why you call them as karyotyping and karyotype. And we have a principle or logic to understand how we can get this particular chromosomes in that particular shape and how we can just identify them. And based on this particular staining and procedures, and we are going to collect this particular things with a rationale. This is a sequence of the things, how we are going to get this particular karyotype or karyotyping thing done, and identify it and place it in a microscope and see it with the staining like this. And once you have identified this, and we have to place it in a proper, following that particular protocol which has been followed by the Denver classifications and the Paris modification, and we classify it and identify it properly, and that's all. So from this part we understand this particular phenomenon, we call them as this karyotyping is required for diagnosis of the clinical things, which we are going to discuss today about the clinical diagnosis of the use of the karyotyping, and the gene mapping, etc., will be covered in biochem as well as. And the role of the cancer, as I mentioned, fragility of the chromosomes is a clue thing which helps us to identify whether the cell is prone to have cancerous changes or not, whether individual is exposed to the radiographic isolation or radiographic exposures or not. And of course, paternal identifications can be done as well. Now, what we know so far about this particular chromosomes in a female subjects, we are specifying that particular gender here. We have 2n number of the chromosomes, we have 46, and out of that we have these particular autosomes and we have these particular sex chromosomes. And autosomes, we have 22 pairs of chromosomes, and in the sex chromosome 1 pair we have. So out of these particular 1 pair chromosomes we have in a female subjects, we have this particular chromosome, we call them as X and X, whereas in a male subjects, which is over here, is X and Y. So there are 2 isolated difference which is present in this particular genetic pattern on the cells which is present in a male subject and the female subject. Now, our point of concern here to discuss about this particular female subject, which is having this particular chromosome pattern, 22 chromosomes, which is autosome 22A we call it, and this 1 pair XX. Now, what we have observed in a somatic cells, this particular chromosomes which is present in autosomes and as well as sex chromosome, there are some kind of functional changes present in it, and as well as this functional changes is also reflected on the morphological changes as well. So we have 2 X chromosomes in the female subjects. Now, out of these particular 2 X chromosomes in a somatic cell, we observe that 1 X chromosome is working and other X chromosome is non-working. So 1 X chromosome in a female subject is active and other one is inactive. So this particular thing which is present in a somatic cell, that is saying here. So we use the word somatic cell, and we observe this, one of these particular X is inactive, and this inactivation can be observed. That means it is not working, it is not transcripting, or it is not following the genetic informations which each have and transmitting through this particular process of the protein synthesis, etc., etc. Not only that, this particular chromosome which is lying idle, sticking to this particular cell membrane, and this particular isolated which is not working X chromosomes can be visible through staining process, and that particular chromosome which is idle, not working, genetically inactive X chromosome is visible and termed as the sex chromatin, also known as Barr bodies. So this inactivation is observed by the person who has termed this inactivation of X inactivation in a somatic cell. We call this particular phenomenon of inactivation by the name of the discoverer or observer who actually coined this thing, we known as Lion hypothesis. So this is what we are talking about, Lion hypothesis and the Barr bodies. So we have the 2 X chromosomes in the female subjects. In the somatic cells, there is 1 X chromosome is working, whether other is not working. That phenomenon we call them as a Lion hypothesis. Now, what happens to this particular X chromosome which is not working? It is becoming inactive and transformed in the clog of this particular chromatic mass and sticking to the cell membrane and staying there as an inactive mass. We call this as a Barr body also known as sex chromatin. The bar body is observed by a different person, which is Murray Barr, who observed that bar body. But this particular explanation why this particular X chromosome stays in inactive form in a somatic cells in a female subject, that explanation was not given by that particular discoverer. Which is been given by the discoverer, we call them as Lyon hypothesis, which you are getting. Now, what happens over here? So, we have two X chromosomes in a female subject. Now, in early phase of embryonic life, yet we are born, in an early phase means 4 weeks, 3 weeks, 2 weeks, around that time of the embryonic life, this particular inactivation switches. Now, we have this particular X chromosomes in a female subject, we are getting one X chromosome is coming from our father and other one is coming from our mother. So, out of these particular X chromosome, either of whichever it is coming is randomly switched off whenever it is coming in early phase of embryonic life. So, there is no pattern, no mathematics, no logic is there which X chromosome is going to be inactive. It could be paternal, it could be maternal, does not matter. But the only thing is that it happens in the early embryonic life. Before we just like understand this particular inactivation, switching off is done. Now, the second key thing about this observation is that once this is inactivated, this inactivated sets on and continues. That's once inactivated, it cannot be reactivated in the somatic cells. So, this particular inactivation is kind of permanent, happens early in life. It could be paternal and it could be maternal. And the inactive chromosomes is not participating in genetic transcriptions of the knowledge, whatever it is holding it. So, this is a observation which has been observed by this particular discoverer, Lyon, and this particular thing is known as Lyon hypothesis. Now, I am sticking to the word somatic cells. Now, this thing is not applicable for the germ cells. That means, when this particular germ cells are there, this inactivation does not play a role. In a germ cells, there are still two active X chromosome is there. And when this particular division is taking place from the 2 end cells to the end cells, which is the gamete cells which is coming, that particular set receives that 2 active forms of the X chromosome which is divided on. So, this particular phenomenon which I am referring here is related or sticking to these somatic cells. Am I clear? So, it is somatic cell phenomenon which is taking place, permanent inactivations of the X chromosomes. Now, looking at this particular X chromosome, which you have learned that this particular X chromosome has a long arm as a short arm. Now, we have observed this inactivations of this particular X chromosome happens with one of the arm of this X chromosome. We have the long arm of the X chromosome and close to the terminal point of it, we have a region. That particular region we call them as X inactivation center. Now, this particular X inactivation center, X scene in short we call them as, this region is been covered or capped by a methyl group of biochemical substance. So, we see a capping of this terminal end of this long arm of the long arm or Q arm of this X chromosome. This is the P arm of the X chromosome. So, we see this, there is a capping which is taking place around this particular region, terminal end of the long arm of the P, and this is known as methylation. So, the methyl group is adding to this particular region which is known as X inactivation center, and once this particular methyl group attaches to this particular center, it blocks this chromosome functional utility, and this particular chromosome which is adding this particular methyl, it becomes inactive and it is not participating in any forms of transmissions of the knowledge or whatever it is, and it transforms into clogging of this kind of substance. So, it is bends down, melts it and makes a kind of element which looks like this, and on a cell membrane surface of this nucleus which is having looking like this particular bar body, which is known as bar body or sex chromatine. So this is the phenomenon that you observe. So Lion hypothesis or Lion hypothesis, this is about the female subject, somatic cells, 2 X chromosomes. Out of that, one of them gets inactivated and one of the X chromosome that performs. So in a female subject, we see that there are 2 X chromosomes, but basically functionally they are working, living with one functional X chromosome, and other X chromosome is inactive. And this particular inactivation of the X chromosome happens early, very early in phase of life, permanent, cannot be reversed, and this particular process of these inactivations which is taking place, which is done by a process known as methylation, which is adding a methyl group to this particular region on the long arm of X chromosomes, and this particular thing, capping of this X chromosome methylations is known as methylations of the X chromosomes, which turns this into this particular inactive X cells or inactive X chromosomes, which clogs as a bar body, etc., etc. So this is the entire thing of this particular Lion hypothesis bar body phenomenon which is there. Now, why does it happen? Is there any reason or rationale to have this particular thing transformed into it? So we are living with this particular male subjects, we have this all these chromosomes which is having 22 autosomes, and this particular X and Y, we are working with all 46 chromosomes, whereas in the female subjects, they are working with these 45 number of the chromosomes. They are living and working and competing with us with the same number of the chromosomes. So it is basically 46 versus 45, yet they are beating us, aren't they? So why these things is happening? So why one X chromosome is purposefully switched off and to give this particular human race male individual to give an age? Non-disjunction? What is non-disjunction? So why the female subject is not given with the Y, only X chromosome to function with, other kept on inactive? Autosomal recessive? Okay, something more easier than to understand. Okay, anything else? Anything you have in mind? Any other good, bad, ugly reason for it? The female subject should be knowing it, right? They should be proud. They are working with the 45 chromosomes and we are working with the 46 chromosomes, and we are yet giving this same NEET exam and competing it and scoring it, cracking it. So they should be given few marks extra for it, right? Now this is known as the nature selection. We can call it like a nature selection. Nature automatically loves these male boys over female boys, right? And that can be just like represented and like this. So that's why we don't like girls to be ruling, and we don't want male all male world, and that's why this particular phenomenon is taking place. This could be one reason, but this is not. There is a scientific reason for this. Now, if I go back to this particular karyotype picture, it might give you some clue about it. Now you see this, the grouping of this. We never looked at it. We understand this particular thing is happening there, Denver classification and Paris modification. So we see that the X chromosome position and the Y chromosome position in this particular chart. So where do you see in which group the X chromosome is, and where do we see this Y chromosome? So group C has X chromosome, and Y chromosome all the way back. So backbenchers, group G, almost lost a place. So how this particular thing is based on this particular classification taking place? Based on the length of the arms and the positions of the centromere. So this classification is done by this, how this particular length of this particular chromosomes are there, and how these particular chromosomes have the centromere in place, and based on this we classify it. And you see that the size matters here. So more the bigger size, we keep it to the group A, and the less size we keep it towards this particular bottom end short. Now you see that this particular group Z, which consists of this all the small or dwarf guys along with the Y, and Y is a kind of dwarf. The Y chromosome is the smallest chromosome in our body and hardly contains any genetic material in it. Very few proteins are being synthesized by this Y. Whereas this X chromosome is belonging to the middle one, medium size, and has tons of genetic material, and the proteins synthesized by this particular X chromosome is a lot. So you can understand, if you have two X chromosomes which can synthesize hell a lot chromatin materials having with it, can synthesize a lot of proteins, whereas the Y chromosome, which is a dwarf, has only 10 or 15 codes for the proteins. So you can see that there is an inequality will be there, and which is going to be very, very obvious. The females are going to be super female, and there are no place for the boys will be there. So this is known as compensation, also known as doses compensations. So here comes the knowledge takes place. That's why nature says, oh, there's a mistake, I forgot to put some chromosomes in the Y chromosome, and what do I do? What do I do? Once I made this, I cannot reverse it. So they said, okay, fail kori dao, ektaকে নামিয়ে দাও. So we call them as switching of this particular X chromosome taking place afterwards. These chromosomes have got evolved, and this particular chromosome genetic material is taking this particular load. Afterwards it is happening, and that's why this particular phenomenon of this particular Leon hypothesis, that's why we're talking about somatic cell in a female subject, X inactivation, random, complete, permanent, and propagated through mitosis, which is happening, and the bar body is forming, and inactivation center which is activating on this long number of X chromosomes around this particular region, proximal part, and DNA methylation which is taking place, which is basically making this thing. And the purpose for doing this is known as the number one we are seeing here. We call them as doses compensation. So we keep one chromosome X which is functional, other one we mask it, so that one X chromosome, whatever the proteins that is coming, is well enough to cover this particular utilities which is required. Whereas the Y chromosome, whatever it is doing two functions. There are two regions are there in the Y chromosomes which is actually functional. One is synthesizing a protein which is controlling a region, we call them as SRY gene. SRY gene is controlling the sex, which is known as sex determining factor. We'll be coming into it, that particular sex determining factor, in when you are coming to the embryo session. SRY gene, which is present only in Y chromosome, that determines the sex of the individual or embryo. That's the only function that Y chromosome has. And other function which the Y chromosome has, it codes for these particular proteins which synthesize from some growth of the hair in the pinna, which is known as heliotrichosis, which is kind of like a excess hair growth which happens only in the male subjects. So most of these particular proteins, whatever the things which is produced by the Y chromosomes, are of not of good reasons, only 2 or 3 or very few contributions is there. So that's why it can be waved off by masking one X chromosome, and this particular phenomenon is known as doses compensation, to compensate this amount of the protein synthesized in a male subject and in a female subject. Are we clear? What do we mean by the doses compensation? Why this compensation was necessary? Because the X chromosomes are not controlling or not having enough genetic material to code for the proteins, and if you have this 2 X chromosome comparing to this particular X and Y, we have very huge amount of the deficiency or difference of these proteins will be there in a male subject and a female subject, and automatically it will be selecting the female subject as a more superpower compared to the male subjects. To keep a balance of the species, this particular thing has happened, and this has been hypothesis by this Lyon. That's why it's known as Lyon's hypothesis, with doses compensation. If you go and study science, you will get this particular tons of explanation on this particular doses compensation. This is one aspect. Other thing, we call them as variability of expression. That means which X chromosome is going to be suppressed, we do not know. It could be paternal, it could be maternal. So there are some aspects which is this one X chromosome is carrying in the father, it may not be present in a mother. Whereas vice versa, the mother have particular expression of the X chromosomes which may not be expressing in the father's X chromosome. So there is an individual variance in there will be there in a siblings. So in a same individuals which have got one X chromosome is kind of suppressed may have a different expression rather than other X chromosome which is expressed in the same other sibling which may have a different varieties. So there is a variability of expression, variability of the protein expression, and this particular development will be there based on this particular X inactivation. So that is one is known as variability of expression. Mosaicism we'll talk about little later as these things progresses. So this is about the doses compensation and this Lyon hypothesis that you have to know. Sometimes we see these complex things coming as an exam short note along with the bar bodies. So you have to know about the bar bodies. If you have to talk about this particular bar bodies, the Lyon hypothesis will be coming in, and the bar bodies is the observation. That's why I am saying this phenomenon, Murray Bar observed this phenomenon which is having this nucleus on the nuclear membrane, there is a chromatin which is sticking to it. He didn't know what this particular thing is there, which is being expressed or explained by this lady, which is done as a Lyon hypothesis. Now what is important out here, the number of the bar bodies is important. In a normal 2x female subject, we have one bar body present. That means one X is inactive, that is lying there. So the number of the bar body is there, which is single in a female number subject in a somatic cells. Now if you have more than one X chromosome, more than two X chromosomes, so what would be the number of the bar bodies? So if you, for example, we have 3 X chromosome in a female subject in a somatic cell. So how many bar bodies will be there? So there is a rule of bar bodies there. So we call this as a rule number bar bodies, number of the bar bodies. So X chromosome number -1 is the rule of identifying it. So in a female subject, if you are doing a karyotyping or if you are looking at and you are getting this particular bar bodies which is more than 1, that means they have extra pair of X chromosome which is present and which basically triggers to explore more, explore farther. So this is what. Now on the flip side, you are doing a mucosal scraping examination of a female subject and you are examining and seeing that there is an absence of bar body in that scraping. What does it mean? So 0 bar body in a scraping. Is there a trouble or a normal thing? Trouble or normal? Trouble or normal? So no bar body is a normal thing or not a normal thing? That's what you should be knowing. So what is normal? That's what you have to know. Bar body in a female somatic cell is a normal or not? Is normal. Sure. How much sure? 80% sure? 90% sure? 10% sure? I see the confidence is dipping low, that's why I put the coin. So what is normal? Bar body in a female subject in a somatic cell, is it normal or not a normal phenomenon? Again I get a mixed kind of expression. So in a normal thing, that means I mean 2n number cells, that's the normal thing which I am referring to. If you scrap this mucosal smear, stain it, whether you are going to see any bar body or not. Yes, that's a normal thing. So single bar body in a 2x female in a somatic cell is normal. It's 100% normal. So once you know this normal, there's a deviation from the normal will be abnormal. So here brings the question. You get two bar bodies in a female somatic cell scapping. Is it normal or abnormal? I didn't hear you. Abnormal. Okay. You do not see any bar body in a somatic cell or a normal female 2X person. Is it normal or non-normal? Abnormal. So one number bar body is a normal thing. Anything more or less is abnormal. So if you miss a bar body in a female subject, that means it's not normal. If you find two bar bodies instead of the one, that's not normal. So once you know the normal, then you can just like go for the abnormal thing, right? You can say that this is diseased or not diseased. Or else it will be like this. I have made one student, you may have diabetes or Down syndrome. I do not know. It could be something like that. So you'll be in puzzle unless until you don't know the normal things. That's what you would be knowing the normal thing, and anything deviations from the normal would be abnormal things. And we have to explore, understand these things. Getting it? Good. So from the bar bodies, sex chromatin, the same phenomenon which you have seen. So this is what we have so far summarized together. We have to know karyotyping, procedure, and Lyon hypothesis with the bar bodies, which is doses compensation we will learn about. Doses compensation, that means the dose of the X chromosomes need to be compensated. That's why one X chromosome dose is compensated by inactivating by other one. That's why one X chromosome is capable of taking care of things, whereas this in male subjects, one X chromosome and Y chromosome 1 is taking load. So we are having extra benefits by having this particular God's phenomenon. You remember that. Coming from it, so next chapter about it, or just introducing it, not digging deep into it. So this is the applied thing, chromosomal aberration. So we have to know this, what is chromosomal aberrations. So in a human species, we have 2n number of chromosomes, and out of this particular 2n somatic cells, we have this particular 2n cells, which is 22 plus XY or XX, and in a gamete cells, we have 23 chromosomes, 22 autosomes, and one is X chromosome, X or Y depending on. So this is the normal thing that we must be knowing. Based on this normal thing, we will be learning the abnormal things. Now if we have deviations of these particular normal things, we call this as aberration. If there is a chromosome which is having an abnormal thing, we call them as chromosomal aberrations. That means there's abnormal chromosomal things are there. Now there would be two kinds of aberrations or abnormalities could be present involving the chromosomes. One is a numeric abnormality. That means the number of the chromosomes is erroneous. Either 2n or n, something is going wrong. So we have to count the numbers of the normal thing, 46. Out of this, we have to split it 22 pairs, X and Y, like that. So we call them as numeric changes of this particular number changes, gains or losses of the chromosome numbers. For that, we have to do the karyotyping thing. Other thing, there will be a loss of the chromosome arms itself, genetic material itself. So this is also known as aberration. So this particular aberration either involving the structural changes of the individual chromosome or the numeric number changes of the chromosome itself. So this particular phenomenon, we call this as together as chromosomal aberration. So this summarizingly, this is we can talk it about this chromosomal aberrations. You see that there can be classified of two groups. One is structural changes. That means we'll look into the chromosomes, long arm, short arm, centromeres, etc., etc., and there might be some problem within this particular structure itself. Maybe it is short, maybe it is deleted, maybe it is having a different shape, etc., etc. So it could have a duplication, it might have a deletion, it might have an inversion, maybe just like a switched off, flipped off, and maybe having a changes in position, translocation. This could be a structural changes, or else we could have a numerical changes. Numbers of the chromosomes may be erroneous. That means it can be classified into two ways. One is euploidy, another is known as aneuploidy. What are these? So we count these particular somatic cells or gonad cells in terms of n or 2n. So if we have a somatic cell which only have n number chromosomes, that means it is an error of the numeric error of the chromosomes, and we call this error as euploidy. If you have a somatic cell which contains 3n chromosome, that means 46 plus 23, an extra n pair is coming in. That is also numeric abnormalities of this chromosomal aberration. We call them as euploidy, triploidy, tetraploidy, and polyploidy, like this. That means in terms of n, 2n, 3n, 4n, xn multiple by the n. That means the number which is haploid or diploid which is replicated likewise. Clear? Now, if we have a single extra chromosome there, one extra chromosome there, then we call this particular aberration as aneuploidy. That means we have 47, 45, 48 chromosomes are there, not the entire set is there. So this kind of numeric abnormality of the chromosomes, we call them as aneuploidy. We call them as monosomy, trisomy, tetrasomy, like it. 4 pair of chromosomes are there, 3, 2, 1, 0, like that. Clear or not? So these basic classifications you have to keep in mind about chromosomal aberration. Structural aberration, that means the structures of the chromosomes may be broken, partly it is missing. So a chromosome is, middle portions is missing, we call them as deletion. A portion which is deleted and switches the position, translocation. Likewise, a chromosome may be having a ring formation, we call them as a ring chromosome. That particular phenomenon which is falling on the structural changes of the chromosomes, which is maybe involving the loss of DNA or may not have a loss of DNA. So out of this, we are just talking about one of these particular chromosomal aberrations, which is numeric abnormality, which you have to know about this particular aneuploidy. This is one of these particular phenomenon. We are talking here as a disease as Down syndrome, which is one of the familiar thing, which you see that, which is a very high incidence of this chromosomal numeric abnormality. We see that we are facing in a human species, we known as Down syndrome. You see this incidence over here, which is 1 in 1100 births. That means it's pretty common, pretty random. So we see this particular numeric chromosomal abnormality is in forms of Down syndrome, where you see that there is a trisomy of 21 chromosomes. So what kind of chromosomal abnormality it is? Numeric or structural? Numeric. So we have a number extra. What number extra? Trisomy of 21. That means 21 chromosome, instead of the 2, we have 3. What kind of ploidy it will be? Aneuploidy or polyploidy? Aneuploidy. Clear? Great. So this is how it is there. So we have this particular extra 21 chromosome is there. We have a reason to have this particular thing which is happening here. One of the reasons why we may have this particular extra 1 chromosome, which is trisomy, we call them as non-disjunction. That means the chromosomes were coming to this particular separation point, and one is not separated completely and goes together in a point. So there is a non-disjunction. The separations of the centromere is not taking place, not pulling this particular chromosome arms in 2 different directions to the different poles, south pole and north pole. Instead, this chromatin fibers is not formed properly. There is a non-separations of this particular non-centromere and pulling this particular 21 pair of chromosome to one side. So one of the cells which is getting this particular chromosome, which is 21 pairs of 21 chromosome, which is 1 in excess, other is getting 0. So this is one of the phenomenon which is known as non-disjunction. Other is translocations and mosaicism. We will be talking about this phenomenon in a subsequent sessions. Now, if you do a karyotype of this particular individual, we see an extra pair of the chromosome 21. So we see this particular chromosome placed over here, we call them as ideogram, and we count the numbers, we see an extra pair chromosome there. We call this as a trisomy of the 21 pair of the chromosomes. Now, how do the person look like? We call them as phenotypic manifestations. That means we know the genetic makeover, what happening there. we understand this particular chromosomal separation, why this particular non-disjunction is taking place and bringing this thing, and how do the person look like. We call this as a phenotypic manifestations, like morphology. If the person stands before me and asks me to just like describe the person, how the person look like, that is what we known as phenotypic manifestations. You get it? Phenotypic manifestations. একটা লোক যদি সামনে এসে দাঁড়ায়, looking at it, we see the changes or abnormal thing which is observed in that particular person, and we describe that thing, and that particular description matters to us. So looking at this thing about this person, the flat faces. The flat faces is usually we see it from the sides. Face is normally bulged outside. This particular person having a flat faces, if you're looking from the sides, they have this particular shape of the head is rounded and epicanthal folds on the eye. We have this particular inner side of the eye, we have a small fold. This particular epicanthal fold of the eye have a typical pattern on this particular individual. If you see this particular picture, you see that this inner aspects of the eye, you see that this region we call them as epicanthal fold. So this particular epicanthal fold in this individual is missing. So this folds which is present in the nasal side of the ear is missing. We call them as particular pattern or down pattern of epicanthal folds. If you look at the arms, they are wide and they are short. So the arm size is usually short. Hypotonia, that means the person have a poor muscle tone. That means it looks like the person is having a little bit weaker in a muscle texture is concerned. How do you look at it? Usually this particular person have their tongue sticking out of the mouth. So this usually we see this person who are coming, the mouth is open and the tongue is sticking out because of the tone of the tongue is less and it is coming out. We call this a hypotonia of the muscle, can be observed by observing the person. Second thing is that the short stature, which is usually they are short in height and they are having some kind of finger pattern problem or finger pattern which is like Down syndrome pattern there is there. So if you observe the fingerprints on this particular person, the Down syndrome pattern is observed. So that particular dermoglyphic patterns which is observed in here can be documented by taking this particular fingerprints on it. And last not but least, this particular persons are usually having some kind of problem with these cognitive errors. So there are developmental milestones involving this particular cognitive part is little bit delayed or sometimes is grossly delayed. So this particular person have a cognitive ability to understand, comprehend, is relatively poor compared to the normal individuals. So they are a cognitively weak individuals compared in a way we are presenting it. They may have some cognitive stability and integrity and strength in some of the areas like music, etc., etc., but reading, writing, the way of the normal or the traditional way of teaching, it's very difficult to cope up with this particular cognitive functions what they have with them. So these are the things which is observed by this particular individual. This is the genotypic pattern or genotypic error, and this is the phenotypic error or phenotypic observation, that is what you are saying. So whenever you are going to replicate this Down syndrome as answering it during examination as an exam short note, we have to mention about this particular genetic error which is genetic problem. That's what you are talking about, this trisomy of the chromosomes, and you have to explain why this particular trisomy of the chromosomes happening. Non-disjunctions is one of the prominent reasons. We will be coming into non-disjunctions, translocations, some mosaicism in the subsequent sessions. These are the prime reasons for this. Other thing, we have to talk about this phenotypic. How do the person look like? That's what you have to explain it quickly and in a short words like this. And this particular persons have got like this particular normal pattern of this incidence of the Down syndrome is there. So this is about this particular Down syndrome we are talking today. Next day subsequently we will talk about some other chromosomal errors, etc., etc., karyotypic errors. So prepare the Down syndrome for the examination, exam short note. Just like 10 sentence, you have to prepare at least 8 to 10 sentence. Thank you.
urine analysis. Okay. As you already know that we have take biomolecules in our diet, such like carbohydrate, proteins, lipid, fat, all the things we take in our diet. And after taking in the diet, they go into the process of digestion and absorption. And lastly, they convert it into some substrate. Substrate means either in pyruvate or glucose, which further on different processes goes on and metabolize it. Okay. But all the biomolecules generally have some metabolic waste product, such like protein. Protein are finally metabolized and excrete urea. So urea is the final metabolic waste product of protein. Such like uric acid. Uric acid is a metabolic waste product of nucleic acid. Okay. So what is that? This is what is urea, what is creatinine? This is non-proteaginous nitrogen substances. We call these substances as NPN substances. Okay. But now today criteria of investigation with a urine analysis, we prognosis a particular disease by identification of some abnormal constituents in the urine. Okay. So firstly you understand the urine analysis. Urine is a sample in which we investigate some abnormal constituents. Okay. Before going to know about abnormal constituent, what we know? Normal constituents. Okay. So we divide the sample majorly two types. It is two types of urine analysis. The first one is normal constituents urine. Firstly, understand what is meaning of normal urine. What is the meaning of normal urine sample? Okay. Second type is pathological urine. First we understand what is normal. If we take the sample from a healthy person, from a person who don't have any kind of disorder or disease, okay, these kind of samples we called normal or healthy urine sample. Healthy urine sample. If we want to differentiate it, normal urine constituent means we collect the sample of urine sample from normal person who doesn't possess any kind of disorder or disease. First thing. Second one is pathological urine. As you understand, pathogens means a virus, bacteria, any kind of foreign antigens who causes the disease. A person who are suffer from any kind of inborn disease, any kind of metabolic disorder, any kind of disease, we take the sample from this such persons. We call this sample as pathological urine sample. Okay. Now, first to understand how can we take the urine sample means how can you differentiate it? We take the random sample. Random sample means we collect urine sample within 24 hours at any time. We collect urine sample between 24 hours at any time. Now fasting urine sample. We collect first morning sample of urine. First morning a sample of urine for the identification of different constituents. Okay. I am not discuss here abnormal constituent of the urine because it is the second part of this syllabus. Today we discuss normal constituent of urine. Okay. But overall view I will give to you. Pathological urine sample we also called abnormal constituents of urine. Abnormal constituents of urine. Okay. Now for urine analysis, just like this is our sample, this is urine sample, we go for further examination of urine. What I say? I say we collect the urine sample, firstly go for physical examination of urine. After then we perform some of the tests. We call this examination called chemical examination of urine. In the next step, we make a slide of urine sample and see under the microscope in magnifications. We call this example microscopic examination of urine. Okay. And further on, we perform some cultures to check the sensitivity of some bacteria or viruses in the urine sample. We call this examination called bacteriological examination of urine. Okay. So first one is physical examination of urine. In the physical examination of urine, we see some of the parameters in which we don't perform any kind of chemical test, any test. Okay, just like the first, for physical examination, we see the volume. Volume in 24 hours. How much a person excrete a urine sample within 24 hours. This is a very important parameter. Okay. Further on, we study topic by topic. You understand why it is important to study about volume. Second one, we check the acid or basis of this urine sample by investigating pH. What is the full form of pH? Very good. Potentials of hydrogen. Now third one, we check appearance. Appearance means whether it is a transparent, whether it is a translucent, or whether it is a fumes like. I will also tell the causes why we have seen such kind of different appearance of this urine. Appearance. Fourth one is, tell me which one, fourth one? Smell or odor. Fifth one, color. Sixth one is specific gravity. We understand all this one by one. Okay. Now, second examination is chemical examination of urine. Chemical examination of urine. Okay. So chemical examination of urine is just only by the use of some reagent, we perform some tests to identify a normal constituents in the urine, such like creatinine, to identify whether, because it is normally present, creatinine is normally present, creatinine, uric acid, urea, don't talk, don't talk. Uric acid, urea. Okay. Glucose और शुगर कर लीजिए, एनी काइंड ऑफ शुगर, ठीक है. फिफ्थ वन कीटोन बॉडीज, सिक्स्थ वन बाइल साल्ट. So all these tests and some of the major test for blood also, test for blood. Test for blood. We perform more of the tests in the urine sample, and this kind of examination is called chemical examination of urine. What we call chemical examination of urine. Okay. Now further on, we go for next examination. We see the urine sample under microscope, and we call this examination called microscopic examination. In the microscopic examination, what we see? We see some pus cells in the urine, some RBC, some crystals. Okay. You don't like it? And last one is, this is called bacteriological examination of urine. Bacteriological examination of urine. Bacteriological examination of urine. In this bacteriological examination, we do urine culture. We do urine culture. We do urine culture. Okay. Now today we are going to discuss about physical examination of urine. Now make a heading: physical examination of urine. First parameter of physical examination of urine is volume. Volume. Okay. Normal output of urine is 600 to 2500 ml per 24 hours oblique per day. Okay, this is normal output of the urine. In the next year, when you attend the inpatient ward, I think next year, third year, then you will see those patients who are admitted, we put the catheters, we put the urine collection bags during admission. Why? Because by the volume we can what is the major aim of our to check the volume or other things? We see the prognosis of the disease. Okay, because those patients who are on oral antibiotic therapy and different types of drugs, what kind of drug they affect on this urine sample, we see that in the urine catheters. Okay, so normal out of the urine and average urine output is 150.24 hours. Okay. These all are the normal things. Now tell me the color of the urine. Yes. Pale yellow, oblique, straw color. How many students know Hindi well? समझ में आता है? बोलना आता है? सभी को? बहुत अच्छे. बांग्ला किसी को आता बोलना? सभी को? कुछ लोगों को आता है. ठीक है. तो मुझे बांग्ला बोलना नहीं आता. ठीक है. It is straw color means शुद्ध हिंदी में इसको बोलते हैं भूसा. हाँ हाँ, चारा वाला भूसा. तो उसका जो कलर है उसको बोलेंगे स्ट्रॉ कलर, आइदर पील येलो कलर. ओके. कैन यू एनीवन टेल मी which constituent is present which is responsible for coloration of urine? Bile salt, bilirubin. I always tell you one thing from the first batch to all of them. Think before you speak. Think before you speak. In the medical courses, from the first day to the last day, you will just understand which thing is right, which thing is wrong. When somebody is asking the question, it is not like a garbage bucket. कुछ भी बोल दिया. Every word and on value. आप सबका आंसर गलत है, सही है, लेकिन उसके पहले सोचो. अगर यूरिन में बिलिरुबिन आएगा, if the bilirubin comes in the urine, then patient may suffer from a disease called jaundice. Understand? It is not normally present. I will talk normal constituent which is presented. It is not bilirubin. It is urochrome, urobilinogen. What we call urobilinogen. Understand? अगर नहीं आता है मत आंसर दो, चुपचाप बैठो, कोई दिक्कत नहीं है. अगर आता है, कॉन्फिडेंट है, तो आंसर दीजिए. ठीक है. तो इसमें लिखिएगा, पिगमेंट में लिखिएगा. इसमें मैं 2-3 नोट डाल के कुछ लिखिए. इसमें डोंट टॉक, प्लीज बी साइलेंट इन माय क्लास. पिगमेंट में लिखिएगा यूरोक्रोम कॉमा compound of urobilinogen and urobilin comma their final based product resulting from the breakdown of heme. Okay. Now this is your color. Now third important parameter is appearance. Appearance means we take the urine sample, we collect the urine sample, and we observe this urine sample in the light. Okay. If this is the waste product, all of these coming from the heme, you directly say, or I will say it is converted by the bilirubin. It is also the second point. Understand? Because hemoglobin, it is basically what happens. There is the destruction of the RBC. Okay, it is contain what? It is hemoglobin. globin. Globin is the protein, heme is the iron. Firstly, it is breakdown, then finally breakdown of heme is converted into bilirubin. And this is further going on separate other processes, conjugations, unconjugation, indirect metabolism. Nextly, in the next lecture, we will discuss all of these things. And lastly, it is converted into urobilinogen and straccobilinogen. Urobilinogen responsible for the coloration of urine and straccobilinogen responsible for the coloration of fecal material, yellowness of fecal material. Understand? So we directly say it is a metabolic waste product of urobilinogen and urobilin. Now appearance. Appearance means we take the urine sample in a glass test tube and we examine this urine sample. The normal person urine is transparent, clear. It is transparent, clear, without any turbidity, without any turbidity. Okay. This is appearance. Now fourth point. Fourth point, you write it. Odor or smell. इसमें लिखिएगा. The order of normal urine is faint, ammonical, Can you tell me why the order of the urine is having order of ammonical? Because most of the disease, some kind of bacteriological infections also identified by the foul smell of the urine. Okay. When we take the sample of urine, there is the presence of one abnormal constituent called urea. And these urea further on, if we left out urine sample for few minutes, the bacteria processing this urea and convert it into ammonia. And due to this ammonia, there is a smell of ammonical odor. Okay. So this is by the bacterial activity, some ammonical smell is there. And if some kind of foul smell is coming, such like in the case of ketones, diabetic ketoacidosis, there is the smell of acetone. Okay, such like in the case of phenylketonuria. I am not discussing here in detail because in abnormal constituent we discuss in detail. Okay, so odor, smell is faint, ammonical. Now make specific gravity. Second one, last fifth one is specific gravity. Specific gravity. First you write it the definition. Urine specific gravity means solute concentration of urine in urine sample. Solute concentration of urine in urine sample. Okay. So normal specific gravity is 1.015 to 1.022. And average is 1.016. Specific gravity is very important parameter. What do you understand by specific gravity? That is presence of solute concentration in the solution. You already read the topic of solution in your chemistry. In which class? Class 11th or 12th? 12th. Okay. So there is some normality, molality, all these units are there. But concentration of solute in a solution we measure by specific gravity. Now you tell me the question. You tell me when the specific gravity is increases. Give the answer in respect to urine excretion. How will you correlate with the volume? Means in the case of such like when the urine output is more, the specific gravity is less. If the urine output is less, the specific gravity is more. So now you tell me how these urines are formed. Generally, if you know the excretion of the urine, what happens in our kidney, the blood is filtrate through glomerular. By which? Glomerular. And how much it is filtered in 1 minute, we call this term glomerular filtration rate. And the fluid we obtained after the glomerular filtration rate is called glomerular filtrate. It is the first process of urine formation. Now in the second step, there is reabsorption of some abnormal constituent, normal constituent through renal tubules. If our renal tubules is working well, the specific gravity is to be maintained. If our renal tubules is not working well, our specific gravity is altered, changes. Okay? So specific gravity also shows the working ability of the renal tubules in the kidney, Okay? Now write it pH. Okay, just a minute. One thing we will left here. In the next class or further on next class, we also calculate the specific gravity of urine sample. Okay. Today, I can make a diagram of this. What is that? This is called urinometer. What is that? Urinometer. Have you seen before? Have you seen such kind of instrument in dairy? Lactometer. Lactometer is also, you see, it is like that. What they check in dairy? They check the content of fat in the milk, how much fat is present. Okay. But in our urine meter, we check the specific gravity in this urine by this urinometer. This urinometer you all of you see and identify. And this question asked in your spotting exam. During the practical exam, I will tell you, you will identify the instrument and write it about it. Write it uses. Okay. After this, you identify, sir, this is a urinometer, and what are the uses of this? To calculate the specific gravity of urine sample. Okay. Because spotting and spotters are a part of your examination. Spotters are a part of your examinations in all your anatomy and physiology and biochemistry. And it is a very good examination because within half minute you identify a particular instrument, you identify a case, you identify a reagent or a test and write it within a time. So this is the one of the most important spotter for an exam. This is urinometer, and what is the use of this? It is used for calculate specific gravity. Okay. And what is this black color? Anyone can tell? This is lead. Okay. Now write it pH. pH. Urine is slightly acidic. Urine is slightly acidic. Urine is slightly acidic. The value varies from 4.5 to 8.0. 4.5 to 8.0. 4.5 to 8.0. 4.5 to 8.0. It is important to know the pH of the urine. How will you measure the pH? Tell me, very good. You tell. What is it confidently? क्या बोला अभी? तुमसे तो पूछा नहीं है. तुमसे नहीं पूछा था. हाँ, क्या बोला था? Very good. Litmus paper. What I tell you, we are not performing any test. We do physical examination. We use litmus paper. If you know the answer, you tell confidently. Litmus paper. We use litmus paper. By the changing of the color of this litmus paper, we identify whether it is acidic or basic. And further, if we want to know the particular pH value, we go for in pH meter. Okay, and it is important to know the value of the pH, to know the pH of the urine. Why? Because we have some of the diseases related with our metabolism called metabolic acidosis, respiratory acidosis, metabolic alkalosis, respiratory alkalosis, in diabetic ketoacidosis, in phenylketonuria, and major of the disease, more of the disease in which our urine pH is become more acidic, more alkaline. Okay, so it is important. And average, if we calculate the average of this is 6.0. 6.0. Student, there is a one term we use, physiological oblique pathological. You understand the difference between both of these terms. What is the meaning of physiological? What is the meaning of pathological? If we have a disease, if we have some disorder in our body, we call this pathological. But if we have some condition in which the value is changed, but it is not a disorder, it is called physiological. We talk about physiological. If we say, tell me the physiological pH of the body, then we ask physiological normal pH of blood. Okay, such like in the case, such like a condition is what? In heavy exercise, if a person is doing running, if a person is doing gym or heavy exercise, then there is the pH of the urine become changes. If a person taking heavy protein diet doing exercise, the pH of this physiological pH become changes and the urine pH become acidic. But here I am not talking about any disorder. It is general concept. Such like in the case, it is for heavy exercise and during pregnancy. It is a general condition of the body. It is not a disease. Okay. Now, basic, how the urine converted more basic? If a person taking more green leafy vegetables, okay, more citrus fruit diet, the urine become alkaline in nature. Okay, so these all are physical examination of urine, and it is very important part of urine analysis. All of you understand? समझ में आया कि नहीं आया? नहीं आया? आवाज ही नहीं आ रही? अरे ब्रेकफास्ट किया है? समझ में आया?